So today we are going to discuss about Addison's disease. My name is Dr. Raja Nadir Jalal. So it is a very important topic in endocrinology. Let's start. In this video I am going to discuss about hypothalamic pituitary axis, some adrenal disorders, then specifically about adrenal insufficiency and primary adrenal insufficiency, which is called Addison's disease. I will discuss about etiology, symptoms, diagnosis, treatment, and patient's education. After that, I will discuss management of acute Addisonian crisis. In the end, I will go through some question scenarios to better understand about the diagnosis and management of this condition, and finally you would be able to see all the references. So hypothalamic pituitary adrenaline axis, its key role is basic homeostasis and the body's response to stress. Neuroendocrine neurons in the hypothalamus synthesize and secrete two hormones which regulate the anterior lobe of the pituitary gland. These hormones are vasopressin and corticotropin releasing hormone. Now coming to hypothalamic pituitary adrenal control and feedback system. In response to circadian rhythm or stress, the hypothalamus increases the secretion of corticotropin releasing hormone, which is CRH. This hormone acts upon the anterior pituitary gland to secrete adrenocorticotropic hormone or ACTH. This ACTH circulates through the blood and reaches to the adrenal cortex to stimulate the release of cortisol into the bloodstream. Now feedback is that this cortisol, which is released by the adrenal cortex, this in turn acts back on the hypothalamus and pituitary to suppress further release of CRH and ACTH production in a negative feedback cycle. It means when there is more than normal level of cortisol in the blood, it suppresses secretions of corticotropic corticotropin releasing hormone CRH and adrenocorticotropic hormone, that is ACTH. And if the level of cortisol is lower than normal, then it increases secretions of CRH and ACTH. From these diagrams you can see that how this feedback system acts. So when adrenal cortex releases glucocorticoids, that is cortisol, and it then negatively suppresses pituitary and hypothalamus to decrease production of corticotropin releasing hormone and adrenocorticotropin hormone. Now coming to adrenal glands, these are two small glands on top of kidneys. Each adrenal gland consists of an outer cortex and inner medulla. Cortex, adrenal cortex, it has three layers. The outer part is called zona glomerulosa and it secretes aldosterone. Middle part is called zona fasciculata and it secretes cortisol. And innermost layer of adrenal cortex is zona reticularis, which secretes various androgens. Then there is adrenal medulla. Adrenal medulla consists of neuronal tissues and produces catecholamines, adrenaline and noradrenaline. This diagram shows the anatomy of the adrenal gland. This is another diagram which shows production of adrenal hormones by adrenal gland. So you can see that zona glomerulosa, it produces mineralocorticoids and aldosterone. Zona fasciculata, it is the main part of adrenal cortex. It produces glucocorticoids. Main hormone is cortisol. And then zona reticularis, which produces androgens in various proportions, and testosterone is produced by zona reticularis. Then there is medulla. Medulla secretes norepinephrine and epinephrine. Now I am going to discuss about the adrenal hormones. First of all is aldosterone. This is stimulated by angiotensin II, and its main function is water and electrolyte balance in the body. It increases sodium and water reabsorption and causes potassium excretion. Next is cortisol. This is its production is stimulated by ACTH in response to stress. It is also known as stress hormone. It is a major stress hormone. It affects many tissues in the body, including the brain. And it also stimulates gluconeogenesis and lipolysis, depresses immune response, and decreases inflammation. Next, various androgens produced by the adrenal gland. These are also stimulated by ACTH, and these are responsible for secondary sexual characters and reproduction. Epinephrines secreted by the neuroendocrine cells of adrenal medulla. These are produced in response to stimuli from the autonomic nervous system, and these are released from adrenal medulla and help in fight or flight response. There are different conditions which can be seen if there are derangements of the adrenal gland. First one is called Cushing syndrome. This is because of excess cortisol. Then there is Conn's syndrome, which is also known as primary hyperaldosteronism. This is as a result of excess aldosterone. Addison's disease, which is our topic for today, it is also known as primary adrenal insufficiency, and it is because not enough cortisol and aldosterone are produced by adrenal gland. Another condition is congenital adrenal hyperplasia. In this, there is too little cortisol and aldosterone, and there are too much androgens. So this derangement is manifested as a virilization in females. And another derangement of the adrenal gland is pheochromocytoma, in which there are high levels of adrenaline from the adrenal medulla are released. Now coming to adrenal insufficiency. Adrenal insufficiency is characterized by a deficiency of adrenal hormones. It can be primary or it can be secondary. Primary adrenal insufficiency is known as Addison's disease. Dysfunction is at the level of adrenal gland. It affects all adrenal cortical hormones, including cortisol, aldosterone, and androgens. It's typically associated with a low plasma cortisol level and an elevated plasma ACTH. Hyperpigmentation of the skin is seen in most cases of primary adrenal insufficiency. On the other hand, secondary adrenal insufficiency is dysfunction at the level of hypothalamus or pituitary gland. There is decreased ACTH production, resulting into a decline in or lack of cortisol secretion. Generally only affects cortisol. The most common cause is iatrogenic, that is ACTH deficiency due to prolonged administration of exogenous glucocorticoid therapy, that is steroids. Now I am going to discuss about Addison's disease, which is primary adrenal insufficiency, also known as primary hypoadrenalism and primary adrenal insufficiency. This is failure of adrenal cortex to produce the necessary hormones in sufficient quantity. It is a rare disorder. About 8,400 people in the UK have Addison's disease, most common between the ages of 30 to 50, although it also can affect children and people of any age. Women are affected more than men. Etiology. The most common causes are autoimmune and infections. Autoimmune adrenalitis, the most common cause of Addison's disease in the UK, accounting for 70 to 90% of cases. Infections include disseminated tuberculosis. This is an uncommon cause in the UK, but it is the most common cause of Addison's disease worldwide. Apart from tuberculosis, disseminated fungal infections like histoplasmosis and coccidioidomycosis, HIV, and other systemic bacterial infections can also cause Addison's disease. There is a long list of less common causes, including inherited disorders, hemorrhagic infarction like in sepsis, especially in meningococcemia. This is called Waterhouse Friderichsen syndrome. Then a sepsis due to Pseudomonas aeruginosa can also cause Addison's disease. Hemorrhagic infarction because of anticoagulant therapy or antiphospholipid antibody syndrome can also cause Addison's disease. There are many drugs which can cause Addison's disease. There is a list you can see. Then metastasis, that is cancer cells from primary source can come and destroy the adrenal gland. Then infiltrative disorders, storage disorders like amyloidosis and hemochromatosis can cause Addison's disease. Congenital adrenal hyperplasia, resistance to ACTH, and surgical removal of the gland when there is bilateral removal of adrenal glands. There is another condition which is called Nelson syndrome. It is rapid enlargement of a pituitary adenoma following removal of both adrenal glands. As a result, there is lack of negative feedback of cortisol on ACTH secretion. This is seen particularly in those patients who are not compliant with hydrocortisone replacement therapy. This diagram shows Sign and symptoms of Addison's disease. Symptoms: patient may come with fatigue, lassitude, general weakness and malaise, loss of appetite, postural hypotension, dizziness, syncope. May come with GI symptoms like nausea, vomiting, abdominal pain, diarrhea, constipation, or there may be myalgias, arthralgias, and a decreased libido, and in females maybe amenorrhea. Signs include weight loss, hyperpigmentation, hypotension, thinning of axillary and pubic hair, and vitiligo. Coming to symptoms of primary adrenal insufficiency, symptoms tend to develop gradually over months or years. However, any additional stress may cause symptoms to develop suddenly or get worse, and patient may present with a sudden crisis. We can divide symptoms according to the deficiency of particular hormones. For example, due to cortisol deficiency, patient ex- experiences lack of energy, fatigue, chronic exhaustion, abnormal drowsiness or tiredness, anorexia and unintentional weight loss, muscle weakness, abdominal pain, diarrhea, low mood or mild depression or irritability, hypoglycemia, causing difficulty in concentrating, confusion, anxiety, and even unconsciousness, particularly in children. Then hyperpigmentation, which is brownish discoloration of the skin, lips, and gums, particularly in the palm creases, scars or on pressure points such as knuckles or knees. Anterior pituitary secretes propiomelanocorticotropic hormone, which is converted into melanocyte stimulating hormone and ACTH. In Addison's disease, due to deficiency of cortisol, propiomelanocorticotropic hormone is increased, causing high levels of both melanocyte stimulating hormone and ACTH. This MSH or melanocyte stimulating hormone stimulates melanocytes in the skin to produce excessive melanin and causes hyperpigmentation. This is these these pictures show hyperpigmentation seen in Addison's disease of elbows, palm creases, gums. So, and sometimes vitiligo is also associated with Addison's disease because vitiligo is also an autoimmune disease. So, in if Addison's disease is because of autonomic dysfunction, then in some cases it is also associated with vitiligo. Now coming to symptoms due to aldosterone deficiency. Aldosterone deficiency causes dehydration, low blood pressure, dizziness and fainting, postural hypotension, urinary frequency, increased thirst, and craving for salty foods. And due to sex steroid deficiency, patient experiences loss of libido, menstrual irregularities, amenorrhea in females, and delayed puberty in children. Important thing is that symptoms of Addison's disease may mimic many other diseases which should be kept in differential diagnosis. For example, acute abdomen, gastroenteritis, depression, eating disorders, type 1 diabetes mellitus, chronic fatigue syndrome, and hyperemesis and cloasma of pregnancy. There are many common symptoms which you can see on this slide, and you can realize that how difficult it may be in some cases to differentiate Addison's disease from other common conditions. So you need to keep a high index of suspicion. In many cases, diagnosis is delayed because initial symptoms are non-specific and overlap with many other conditions. So always consider Addison's disease in a person with persistent and non-specific symptoms such as fatigue, hyperpigmentation, GI symptoms like anorexia, weight loss, nausea, vomiting, abdominal pain, and salt craving, musculoskeletal symptoms like muscle weakness, cramps, and joint pains, cardiovascular symptoms such as postural dizziness, and other symptoms like headache, low grade fever, increased thirst, or increased urination, loss of axillary or pubic hair, and menstrual problems in women, delayed puberty in children. So, keep a high index of suspicion. In addition, consider the possibility of Addison's disease in people with hypothyroidism because symptoms of hypothyroidism worsen when levothyroxine is started if patient is also having Addison's disease. Then type 1 diabetes mellitus if patient experiences recurrent unexplained hypoglycemic episodes. In that case also consider concomitant Addison's disease. And in other autoimmune diseases such as vitiligo, pernicious anemia, chronic active hepatitis, alopecia, and celiac disease, these are autoimmune diseases and may have uh, Addison's disease in the background as well. In cases of hyponatremia and hyperkalemia, you should also consider Addison's disease in differentials because hyponatremia is present in 90% and hyperkalemia in 65% of people with established Addison's disease. How to diagnose Addison's disease? It depends upon history, physical sign and symptoms, and your examination and investigations. Typical sign and symptoms which we have discussed, like thin build, weight loss, hyperpigmentation, hypotension, postural hypotension, then past medical history of other autoimmune diseases such as type 1 diabetes, vitiligo, or thyroid disorders. Take family history of any autoimmune disorder. There is increased risk if a close family member has another autoimmune condition such as vitiligo, type 1 diabetes, or hypothyroidism. It is important to take treatment history, especially about long term use or sudden withdrawal of steroids. Then take past surgical history. Take gynecological history in females to exclude Sheehan syndrome, which is postpartum pituitary necrosis caused by blood loss and hypovolemic shock during and after childbirth. It can lead to secondary Addison's disease. Labs for diagnosis you can find anemia, lymphocytosis, and eosinophilia. Then there are electrolyte abnormalities, hyponatremia, and hyperkalemia. There may be low plasma blood glucose. Levels of ACTH are higher than 100 picogram per deciliter, and early morning cortisol level is low. It should be taken between 8 a.m. to 9 a.m. If serum cortisol level is more than 400 nanomole per liter, then adrenal insufficiency is unlikely. Cortisol level should be lower than normal to diagnose Addison's disease. If the serum cortisol level is less than 100 nanomole per liter, adrenal insufficiency is highly likely, so this patient should be admitted to the hospital. If serum cortisol level is between 100 to 400 nanomole per liter, then refer this person to an endocrinologist for further investigations. Another lab abnormality which can be seen is low level of aldosterone, and plasma renin levels are typically high. There is metabolic hyperchloremic acidosis. Organ specific antibodies can be detected in the blood. Adrenal cortex antibodies and 2-hydroxylase antibodies can be found. To confirm the diagnosis, you have to do synectin stimulation test. Synectin test, which is also called adrenocorticotropic hormone stimulation test. Synectin is a synthetic analog of ACTH. A blood sample is taken and tested for cortisol before an injection of synectin. 250 milligram is given IV or IM. Then further blood samples are taken to measure cortisol after 30 minutes and after 60 minutes. Normal response is if cortisol levels increase to more than 500 to 550 nanomole per liter after 30 or 60 minutes. But if the cortisol and aldosterone levels remain low after injection of synectin 250 milligram, it is usually a confirmation of Addison's disease. This test can be performed at any time of the day as the post-stimulation value is used for diagnostic purposes. We may also need imaging such as chest and abdominal radiograph. In case of TB, there may be adrenal calcification. Then CT or MRI cross-sectional scans of adrenals may also help in diagnosis. Coming to treatment of Addison's disease, it is usually initiated by an endocrinologist. Repeat prescriptions may be provided in primary care by the patient's GP. Treatment is daily hormonal replacement therapy, which is lifelong, both glucocorticoids and mineralocorticoids. But androgen replacement is not routinely prescribed in the UK. For glucocorticoid replacement, hydrocortisone is usually used, but longer acting glucocorticoids such as prednisolone and dexamethasone are sometimes used to avoid peaks and troughs in serum levels. Usual adult dose of hydrocortisone is 15 to 30 mg per day in divided doses, and usual dosage in children is 8 to 10 mg per meter square daily in 3 divided doses. Important is that glucocorticoid replacement should resemble the natural cycle of corticosteroid release. So 3 divided doses are usually given: 10 milligram on waking, 5 milligram at noon, and 5 milligram in the early evening. This is to provide even levels of glucocorticoids throughout the day. 2 divided doses may lead to more variation in cortisol levels. Mineralocorticoid replacement, fludrocortisone is usually used. Usual adult dose is 50 to 300 microgram. Children have a much higher mineralocorticoid requirements and they may need salt supplementation as well. Androgen replacement, dehydroepiandrosterone DHEA is used. It is unlicensed but may be prescribed by some specialists, not yet a part of routine clinical practice. Some studies show improvement in fatigue, well being, and sexuality and insulin sensitivity, but not others. Hirsutism appears to be a major side effect of androgen replacement. An important part of treatment of Addison's disease is identifying and treating the underlying cause. For example, tuberculosis, which may need anti-tuberculous treatment for at least 6 months. However, most cases are autoimmune and cannot be cured. Next is adrenal crisis. Addisonian crisis or adrenal crisis is a potentially life-threatening condition that results from an acute insufficiency of adrenal hormones, that is glucocorticoids or mineralocorticoids, and requires immediate treatment. It is important to differentiate an Addisonian crisis from Addison's disease, which has a more gradual course. An Addisonian crisis may develop when adrenal insufficiency goes untreated or the patient experiences stress such as from infection, surgery, trauma, myocardial infarction, dehydration, exposure to cold, burns, or overexertion. All these triggers may precipitate an adrenal crisis in a patient with Addison's disease. Adrenal crisis is a medical emergency. If left untreated, it can lead to coma and death. There is also a risk of hypoxic brain damage if treatment is delayed, which can cause permanent disability. So, who is at risk for adrenal crisis? Patients with Addison's disease or other secondary hypoadrenalism in the event of an acute stressor, such as mentioned triggers mentioned in the previous slide. Then patients with meningococcemia are also at risk. This is called Waterhouse-Friderichsen syndrome. Sudden withdrawal of exogenous corticosteroid can precipitate adrenal crisis. Then pituitary necrosis or pituitary apoplexy. Following bilateral adrenalectomy and following administration of etomidate, which is a general anesthesia. All these are risk factors for adrenal crisis. Clinical presentation of an adrenal crisis. The symptoms are severe and develop suddenly. Severe vomiting and diarrhea, abdominal pain, dizziness, severe drowsiness or loss of consciousness, severe muscle weakness, dehydration, severe dehydration and shock out of proportion to the severity of the current illness, pale, cold, clammy skin and sweating, which are symptoms of shock, then rapid, shallow breathing. How to make a diagnosis during an adrenal crisis? You have to consider various factors in the history which may indicate the cause leading to adrenal crisis. For example, a patient with all the symptoms of adrenal crisis who have gone a recent childbirth or infection, trauma, surgery, or any kind of stress, or in home sudden withdrawal of the prescribed steroids has taken place. Typical clinical presentation will guide you, and labs should warrant immediate treatment. Don't wait for the test results or identifying underlying cause. Start treatment. The patient is always hypotensive and often febrile, may have increased skin pigmentation, and may have purpuric rash in case of meningococcus septicemia. Differential diagnosis. The most important differential diagnosis of adrenal crisis is from other types of shocks, including septic shock, distributive shock due to inflammation such as acute pancreatitis and burns, cardiogenic shock, hypovolemic shock, obstructive shock, that is pulmonary embolism, and cardiac tamponade. So you have to keep in mind all these differentials. Now coming to current guidelines for the management of Addisonian crisis, an acutely ill patient with signs and symptoms suggestive of acute adrenal insufficiency, one should rule out Addisonian crisis, determine the history of steroid use, assess blood pressure, and perform orthostatic measurements, sitting and standing blood pressure, lying, sitting, and standing blood pressure, perform appropriate tests like sodium, potassium, creatinine, urea, TSH, cortisol, and plasma ACTH level. While waiting for the results, treatment should be started. Never delay treatment because of testing. The initial goals of therapy in a patient with acute adrenal insufficiency are volume resuscitation and correction of electrolyte abnormalities. If in doubt and suspicion of Addison's crisis is high, administer IV hydrocortisone and hydrate the patient. During an adrenal crisis, there is not enough time to perform a synectin stimulation test to confirm Addison's disease. In stable patients, this can be considered for the confirmation of diagnosis. All patients with adrenal crisis should be admitted to ICU or high dependency unit for close monitoring of electrolytes and hemodynamic observations. Emergency management of Addison crisis consists of replacement of IV fluids with 0.9% normal saline. Usually large amounts up to 2 to 3 liters per hour are needed until hypotension is corrected. Then sodium chloride can be switched to 5% dextrose water with 0.45% normal saline solution. You have to give IV hydrocortisone 100 milligram bolus or dexamethasone 4 milligram bolus. First day is hydrocortisone 100 milligram every 6 to 8 hours and slowly tapered over the next 3 to 4 days. Maintenance dosing is 15 to 25 milligram hydrocortisone per day orally in 2 to 3 divided doses, or prednisolone 5 milligram in the morning and 2.5 milligram in the evening. Patients with Addison's disease will also require mineralocorticoid replacement with fludrocortisone. Dose is 0.1 milligram per day. Higher or lower doses may be required based on symptoms, patient's blood pressure, fluid retention, and serum sodium concentration. If infection is suspected, you might need to give antibiotics and treatment of any underlying cause of the adrenal insufficiency if found. When patient is stable, CT, MRI scans, and chest X-ray can be helpful in determining possible malignant or infectious cause. Patient may be discharged when electrolytes are stabilized and underlying cause is determined. How to avoid an adrenal crisis in future? For this, you have to educate the patient that it is very important to take medication every day at the right time. Keep spare medication, especially if going away, plus an injection kit. Increase the dosage of steroids in certain situations which can precipitate Addisonian crisis. For example, during an illness, infection, surgery, a medical procedure, or an accident. Advise the patient to wear a medical alert bracelet or necklace to inform people or any medical professional that they have Addison's disease and what medication they require in case of an emergency. Patients should inform their close friends or colleagues about their health condition and the signs of adrenal crisis and what they should do in case of an emergency. The patient and a partner or family member may be trained to administer an injection of hydrocortisone in an emergency. And it is also important that patient gets registered with their local ambulance service so they have a record of the patient who would require a steroid injection or tablet in case of a crisis. Prognosis and life expectancy in Addison's disease, the outlook for patients with Addisonian crisis on the time of treatment depends on the time of treatment, how early treatment is started. Delays in treatment usually have poor outcomes. Patients with bilateral adrenal hemorrhage had 100% mortality prior to the era of CT scans, but today, with improved imaging, most of the cases of these patients survive. Patients who present with impaired mental status and loss of consciousness usually do not survive. Life expectancy in Addison's disease patients is normal with treatment. However, it is still a potentially lethal condition with excess mortality in acute adrenal crisis, infection, and sudden death in patients diagnosed at young age. Otherwise, the prognosis is excellent for patients with Addison's disease. Driving issue: if someone diagnosed with Addison's disease and he or she has a bus, coach, or lorry driver, it's their legal obligation to inform the DVLA. Here is a question. A 53-year-old man comes to the physician because progressive weakness and weight loss over the past 2 months. He says he also began noticing areas of his skin getting darker even though it is winter and he is never in the sun. He takes no medications and has no other medical conditions. Physical examination shows no other abnormality except for orthostatic hypotension and hyperpigmentation of his skin. Lab studies shows sodium 130 milliequivalent per liter, chloride 95 milliequivalent per liter, and potassium 6.5 milliequivalent per liter. Which of the following is the most likely diagnosis? So you can see that there is hyperkalemia and skin pigmentation, orthostatic hypotension. So it is a case of Addison's disease. Another question: a 45-year-old woman with AIDS and disseminated histoplasmosis complains of profound weakness, easy fatigability, and anorexia, weight loss, and diarrhea. Lab investigations reveal a serum potassium of 132 milliequivalent per liter, a serum potassium 5.8 milliequivalent per liter, and pH of 7.58. Skin pigmentation is seen on physical examination. Which of the following is the most likely diagnosis? So the answer is primary adrenocortical insufficiency. Another question: a 42-year-old woman with no history of prior surgery complains of extreme weakness and fatigability that has persisted for the last 5 months. She reports nausea and stomach cramps and has had trouble keeping solid foods down. She is hypotensive while sitting and her blood pressure falls even more on standing. She notes increased freckling around her eyes, and on examination her palmar creases appear darkened. Serum potassium is 6.5 milliequivalent per liter. So the diagnosis is Addison's disease. These are the references you can see, and this is the end of this presentation. Thank you very much, and I hope you have enjoyed this presentation. Thank you very much.